Welcome to Healthcare Blindspots. I'm Vivian Kopsinja-Birchall, your host, and I have a special guest, Dr. Boateng Wiafe. He's based in Ghana, and we're going to be talking about his work as an ophthalmologist. But before we get into that, I'd like to invite you, Dr. Wiafe, to kindly introduce yourself. Tell us about you, your journey as an ophthalmologist, and then we'll take it from there. Welcome.
Okay. Briefly, because my journey as an ophthalmologist dates back to 1985. And I have an interesting experience because I have had the opportunity to work on both sides of Africa. In fact, beginning of my career, we worked as missionaries in Zambia for the Seventh-day Adventist Church, where we worked at a very, very remote part of the country, the border with Angola, the Western province. And from there, we came down to the Eastern province of Zambia, and then Lusaka finally was our final station, where we relocated to Ghana in the year 2005. Interestingly, we've been back in Ghana for 20 years. Yeah, but I got my training, both medical and ophthalmology training in Romania. After that, in the year 1992 to 94, I came to London to do my community eye health, and then got a master's degree in community eye health. And after that training, it empowered me to be able to treat communities. And as you know, back in our countries, the population are quite sparse. Zambia had a population density of between 4 and 40 persons per square kilometer, depending on which part of the country you are. And so we had to strategize to make sure there is access to eye care to as many people as possible. I've had the experience of working with nothing to start with. By nothing, I mean nothing. You get to a place, what you have plentiful patients. The rest was actually, and you have to figure out how to do and get the people to access eye health. That was a very, very, I think it was a school for me, because in medical school, you don't learn how to do all these procurements and managing and other things. So you have to start from ground zero, where you have to find people to form a team to work with. Okay, so that team, you have to train them yourself, and then get them to the level where you can do that. But for me, it was a very big school preparing me for the future where I am now. Now, in Zambia, like I mentioned, I worked there for 20 plus years, where all our children were born there. And it was a school because, like I mentioned, everything we had to start from scratch. When I got to Zambia, we were only 8 ophthalmologists, 8. And almost all were in the urban areas, the teaching hospital, apart from me, who was out in the province and so on. And so it was a great experience. Like I mentioned, I spent the first part of my career in Zambia and Malawi, and then my job took me to Botswana, and that sort of thing. Later on in life, when I moved this way, I had the opportunity to work with Operation Eyesight Universal, which is a Canadian-based NGO, which supported my work in Zambia. And moving to Ghana, I was asked to try to establish that organization in West Africa. So we started already we had projects in Kenya, and then Ghana. Then we established one in Rwanda, established in Ethiopia, and now we are also in Liberia. At first, I was the regional director for Africa, and then as I was growing, because we had to establish offices in these countries. Our latest office is in Malawi, where we have a program there, and it's safe and running. But this is about me.
Well, first of all, very, very exciting career that you've had. And, I'm blown away by how many countries you've been to on the continent. It's been, I mean, from West Africa, Eastern Africa, Southern Africa. And, that's different demographics. Although some people tend to think Africa is monolithic, but it's not. All these regions have their uniqueness. And maybe just to even base on that, and also something you mentioned, you studied community eye, I think you called it community eye health, which is which ties a lot into the conversations we're going to have today, the conversation we're having today. When it comes to identifying blind spots, first of all, could you please explain to us what is ophthalmologist? What do you do in your profession?
Okay. This is a very, very pertinent question because there's always a mix-up the different professionals in eye care. The ophthalmologist is actually a medical officer who has specialized in eye care. By that I mean the ophthalmologist is able to treat medical, optical, and surgical eye conditions. We have another cadre, the optometrists. Optometrists are trained professionals whose concern is for primary care and the optical aspect of the eyes, refractions and refractive errors. So all those who need eyeglasses are actually taken care of by the optometrists. Then we do have opticians. Opticians are just, their business is to look at fixing the eyeglasses. So they get the prescription from either the ophthalmologist or the optometrist, and then they put the lenses and the frames together, which produce the eyeglasses. Then we have ophthalmic nurses. Ophthalmic nurses are nurses. Again, before they start, they are registered nurses, and they go for extra training to specialize in how to nurse the eye patient. And so the ophthalmologist is the head of the team who plans and then coordinates the team, because eye care nowadays is teamwork. And without the team, it becomes very tedious. And that's why in my introduction, I mentioned that you get to the place, you have to bring up together a team. And you need all these people to be able to take care of the patients as quickly as possible.
Well, thank you so much for that explanation. It focuses our conversation with your work as an ophthalmologist, as a leader. And interesting enough, healthcare blind spots was based off the nuance of eyesight, because blind spots are, you know, things you cannot see because they are in
Yes.
your blind spot, you know. And
Sure.
so, based off of that, in your career, the span of so many years you've done this in the different parts of Africa, what are some of the key blind spots that you have identified, both that existed before and some that still exist? And I'll just leave it open-ended and take us where you want to take us.
Okay. Okay. Thank you for this fact. One of the key blind spots is actually who is an eye care provider,
Mhm.
because they just call everybody eye doctor. Okay. And so there are different groups. And in fact, when it comes to even among the ophthalmologists, we have subspecialties. There are people who look only after the front part of the eye. Others look at the retina. Others look at oculoplastics. You know, somebody gets an injury and they repair it to make sure the eye looks okay. We have also areas like cancer management in the eye and all those things, which many people are not aware. Many people think that eye problems are just about cataracts or corneal opacities or conjunctivitis, but there are so many. It's a whole world on itself, which if I would like on our conversation yesterday, one of my wishes is that people get to understand eyes and eye diseases like we do understand COVID-19 or HIV/AIDS. So there are several blind spots. That's number one. Number two is, many people do not understand the eye itself and how it works. It's surrounded by huge myths and misconceptions, which if we had the time, we can go deeper into that, because it's the myths and misconceptions, because you just can't believe it that someone is getting blind and they're doing nothing about it. Okay, it's very obvious that you actually see, you are not seeing as you used to see yesterday, but you're not doing anything about it because there are these myths and misconceptions surrounding them. Okay, because you do not understand the eye, there's something we call the unknown middle. Okay, now the unknown middle is when you don't understand it, you just have to assign a reason to it. So you attach it here in Africa, we say due to witchcraft, because I'm doing so well, because when you see my eye, it looks normal. There's nothing wrong with it. The eye doesn't pain, but I'm losing the sight. So maybe someone is jealous. And so because of that concept, we don't do anything about it until it's very, very late. And so the late presentation is due to what I call lack of awareness. Okay. And this lack of awareness is because we do not understand the eye. We do not even know there are several diseases of the body that can affect the eye. Okay? Diseases like diabetes, hypertension, sickle cell disease, cancer. Cancers affect the eyes. In fact, yesterday we came across a 4-year-old or a 3-year-old boy who has cancer of the eye. And again, this could have been detected much earlier, but again, the parents were not aware. Even among our medical people, some of these go, they just give them some eye drops there, and then they keep putting, they're not changing. The parents get bored. Then move on to find better source. So that awareness is one of the issues why there's so much late presentation. Another condition that is very, very common here, by the way, Ghana is ranked number 2. The prevalence of glaucoma in the world is glaucoma. Again, that glaucoma, the eye will look normal. It doesn't hurt, it doesn't become red, but your sight is going slowly. This is due to pressure in the eyes that, if not controlled, will make one blind permanently. Okay. And this is very another blind spot that I'll talk about later on, which if people are educated to look out for them, and I'm not talking just about the common people, but talking even about health workers. They need to know these exist, and once you cannot explain it, just send it to the specialist. Another blind spot is just not being aware of what the burden is, the burden of eye conditions in the community. And I'm talking about this because our decision makers, our policy makers, okay, have the concept, the idea that because eye conditions don't kill, it shouldn't be a priority. So they were assigned to maternal health, to child health, and all those things. Then the eyes are just an afterthought. Again, because it's a blind spot in their area. In fact, in medical school, we spend very little time, maybe 2 weeks, 1 month, the whole training period on eyes. And so the doctor will finish not having enough knowledge about it. And this is one of the areas I do spend a lot of time training people. We run what we call continuing medical education for our frontline health workers, because in the course of their activities, they should be able to know that, yes, this exists in our communities, and we have to look at them. Imagine someone being brought to the clinic for his malaria or his diabetes, and he's not seen. The health worker should be curious enough to find out why that person is actually being led by somebody. And if they looked carefully, they will actually find out that these eyes are not looking normal. Unfortunately, that's a blind spot in our training system. But like I mentioned, diabetes can make one blind. Cataracts, which is because of old age, we say cataract is like gray hair. Whoever gets old enough will develop it. Okay? And then information like if one passes the age of 40, you definitely need eyeglasses. Instead of bringing the texts or the newspaper further away from you, all you need is to put on your eyeglasses and everything will come back to it's again normal aging process. And if someone comes to me, is 40 something or 50 years and reading without glasses, it tells me that person has a problem. So that's so many blind spots. Again, when it comes to the not knowing the magnitude of the problem, we don't prepare adequately budget-wise. Okay? And it's very important that this come to light, because if the health facility doesn't have equipment for the health workers to diagnose these diseases, they'll go undetected, okay? And what will happen is people will present very late when maybe nothing can be done about the condition. And so one thing that we try to do is to do advocacy. We train these people to also learn to talk to their managers, their heads of departments, their directors about the need for these other things. Simple things like how to even measure the pressure of the eye when people come and you are suspecting it. You know, there are facilities who don't have it. And because of just measuring the pressure, which takes only a few seconds, they have to refer the patient miles away.
Right.
And so, yes, please.
No, go on.
These are some of the conditions, some of the blind spots, I would say, across, and it doesn't matter which country in Africa that you go, we have these issues.
Right. I mean, what a comprehensive outlook on these blind spots. There are things that you have mentioned that struck for me. One is the factor of around observation, like if healthcare workers being observant of the patients that are coming in, if they cannot see, and trying to investigate deeper. And the second one was, primary health care workers to be able to identify and diagnose this. So a few things that, some follow up on that. One is that, as you alluded to earlier, some healthcare facilities do not have the capacity to diagnose this. And, so the question to you will be, what has been your experience in areas that don't have this capacity? And the second one about, community engagement, outreach, advocacy is what has, again, based on your experience, what has that experience been when working across the different regions or countries in Africa? And tied to that is, since you've visited different groups of people across the continent, are there any genetic variations in terms of human beings, those who have more vision challenges compared to others, based on either the region in Africa or even between Africans and the rest of the world? And what are those if they're there?
Sure. Thank you. Yeah, thank you so much. Yeah. For some reason, I happen to be one of the few WHO certified primary eye care trainers. Because this dawned on me some time back, we have worked extensively across the continent through the International Agency for the Prevention of Blindness. And we have come up with a manual for training the frontline health workers on what we are talking about now. In fact, what we teach them is the normal eye. It's just the way the finance people teach about currencies, so that you can differentiate between the genuine one and the counterfeit one. Okay, so what we teach them is to know the genuine one, which means if you meet somebody, you should see two parts of the eye, the white part and the black part. That's it. If the white part is not white, it means there's a problem. It can be yellowish, it can be red, it can be brown. Whatever it is not normal, and you refer. The black part also is the same thing. Black part should be black. If it's white or brown or something growing on it and all those things, it means it's not normal. Someone looking at you. Again, we are not teaching them the anatomy and which they teach them, and after they finish, they come home with nothing.
Mm.
What you see, okay? If, say, the eye looks at you, both eyes should look at you straight, not one looking at you, the other one looking that side. That means there's a problem. That's all we're teaching them to do, okay? And then, in case there's an emergency, what do you do? Okay, and this happens, in rural Africa, you find snakes spitting in people's eyes and all kinds of things. And if you went to all the countries rural in Africa, everybody is pointing to the breast milk. Okay, and we try to teach them that breast milk is not readily available. Okay, because when a snake spits in your eyes or when chemical spills in your eyes, all your main is to try and reduce the time of contact between the eye and the chemical or the snake venom. And the most readily thing that you can take without asking for permission is water. Everybody going to the farm carries water. So you just have to do copious lavage before if you still want to look for milk, breast milk, you can go ahead.
Does it even work? Does the breast milk work?
Well, it doesn't hurt, it doesn't help. So, but the point is, because if you can't just go and grab somebody's wife and start milking her because cobra has spat in your eyes. It will take about an hour to explain, and by that time the danger is continuing. And so we teach them very simple, practical things that they can do without any special equipment at that level. Okay. Then we also teach them, if they have time, they can actually measure and see, oh, this is normal, this is not normal, using the VA chart. It looks very complicated, but it's very simple when you are exposed to that. Then we have developed some algorithms which can help them to actually tell whether this is an emergency, this is not, and all those things. So we try to get them to actually be very active in what they are doing. Someone that sits there, you can see that this person is seeing well or not. And we try to get them to get some confidence, some courage to be able to handle these people. The second question was regarding different places in the continent. It's very interesting you are asking this question, because there are diseases, conditions we call focal diseases, like trachoma. Okay? Trachoma is an infection, a bacterial infection that is focused in certain parts of the country. And in very many different places, they have actually names for them. Okay? And I'll give an example. In Kenya, among the Maasais, it's very, very common. In fact, we worked in an area where the prevalence was about 42%. It's almost every other person has the disease. Okay? And there are specific things that need to be done to get rid of it. The WHO came up with called the SAFE strategy, because if it continues, the infection continues, you discover that the eyelashes start growing into the eye. And those places you find, because of this, they even have locally made tweezers to pull the eyelashes out. And they wear it like a necklace. So if it's troubling them, they just pull the eyelashes. Unfortunately, it comes back. We have in Ghana in 2018.
The eyelashes grow on the eye?
Grow towards the eyeball.
Oh, towards the eyeball. Okay, got it.
Yeah, and so it irritates. Each time you blink, it's like brushing the eye.
Okay.
the eyelashes. And I think you have had an eyelash drop into your eye, how uncomfortable it is.
Mm.
Yeah, and repeated this, it gets the cornea to be hazy, and then the patient eventually gets blind. But WHO has come up with a strategy where this whole thing can be eradicated. It's actually regarding in areas where it's dry, dusty, you know, um, and there's so much of cows, cow dungs, and flies, and all those things. And so there are certain areas where you find certain diseases. Fortunately, this is eradicable. It can be eradicated following the WHO recommendations. And we have countries like Ghana has eradicated it recently. I think Benin eradicated it, and so many other countries. The key thing is it is known, it's a well-known fact that trachoma used to be in the UK, and that's why Moorfields Eye Hospital was actually built. When the soldiers were coming from the Mediterranean countries, they came with them, Egypt, and so many of them came with them, so Moorfields was built. But it's just once development comes in the area where water, access to water and sanitation improves, the disease disappears. Okay? In the US, they call a place Ellis Island. When the migrants were coming from Europe, they had to undergo screening for trachoma to be able to make sure they can enter or not. And so this has been an old disease. It has been in our continent and several other countries around the world, and it is possible to eradicate it. The other one is the glaucoma I'm talking about. Glaucoma is also very prevalent in Africa. The type of glaucoma we have here is called open angle glaucoma, and people get blind with it very, very easily because there are no symptoms, okay? And without beliefs, there's late presentation. But it's very, very important to know that Western Africa happens to have more of that than in the other part of Africa. And so when you're talking of these variations, yes, it exists all over, but looks like the prevalence is more in West Africa than in other parts of Africa. In fact, there is a survey we did in 2015. We discovered that in Ghana, the prevalence was around 19.4%, which in literature is around 12% in other parts of the world. And when you come to the Americas, the Caribbeans also have high prevalence of glaucoma. And this is because the pigment in our system is another risk factor. Okay. Yeah. And so, and then when it comes to refractive errors, I mean, those who need eyeglasses, I think you can see from offhand that there are less Africans wearing glasses than the Asians. Okay. But that's something that we need to look at very carefully, because in the same study I was quoting, we discovered that in Ghana, only 5% of those who need eyeglasses actually have them. Hello?
Yeah, I mean, I'm just thinking about that because I had the same conversation with a friend saying, I haven't actually seen many Africans wear glasses, but is it because they don't need them or they cannot afford them?
Again, the same explanations, made some misconceptions. The cost, okay, is another one. Many people believe that if you wear glasses, your eyes become small. so they won't wear it. Many think that children, it's a taboo to see a child wearing eyeglasses. Okay. But the cost to have it, the point where you can have them, it's also another one. You find them only in the cities. In the rural areas, there's no optical shop. And so there you are. And after the study and we published this, and we got lots of companies with cheap eyeglasses coming into our country. We are due to repeat the study. We are all very curious to know what impact all these have made on the numbers.
I'm curious as well. I want to be following your
Yeah,
study.
yeah. Talking about, again, peculiarities, I think you know sickle cell.
Mm.
Sickle cell is another issue here in on our continent. And sickle cell, we have what we call sickle cell retinopathy, where the back of the eye starts bleeding. And that is common. And it looks like from my study, from my stay in both parts of the continent, looks like there's more sickle cell in western part of Africa than in the other part. Okay, of course, diabetes in the past used to be something for the rich people, a disease for the rich and educated. But nowadays we see it all over. And what we see here actually late stage diabetes because it causes retinopathy and it's blinding a lot of Africans. And so there's that myth which thinks that diabetes is for the rich, those who drink milk and eat rich foods, those, but it's not true.
What are some of
Diabetes
the factors
affects,
that have changed that dynamic?
well, fast foods. Fast foods have reached almost every corner of each country. What the type of food we used to eat in the past is not even found anymore.
Mm.
Okay. Um, Remember, our old ladies used to use lots of vegetables and beans, different kinds of beans. There's a type of beans that when we were growing up was very common, the flat white beans. But nowadays, you can't even see it on the market because people are not buying them.
Mm.
But those are the healthy foods that we need to eat rather than our burgers and other things.
Right. And then before you leave
Yeah.
the
And
genetics,
also,
go on.
yeah, yeah, please go ahead.
Yeah,
Please go ahead.
I wanted to ask just before you leave the genetics part of it or the regional part of it, is there any correlation between eye colors and eye-related diseases and challenges? For example, we different people from different parts of the world have different eye colors. In Africa, we mostly say brown, brown eyes, and
Yeah.
most related to that, in your training over the past, one of the reasons I came up with healthcare blind spots was again realizing that in education material, some of the samples used were, were modeling off white people. And has that changed in the trainings, and how, in what ways is that influencing how we catch these diseases and how we track the trends?
Yeah. Actually, this is a very, very important question because, God in his wisdom created us to adapt to the environment where we live. Because we do have the sun all year round, almost 12 hours each day, it's very important. There's something to protect us. I'll just give you a very easy example. you know persons with albinism. Okay? When you look at their eyes, it's not like yours or mine. Okay? And for them, like daylight is like you are shining a bright light into their eyes. Okay? Because they don't have enough pigment at the back of their eyes. And then the iris too is either green or something. I mean, it's not brown. The brown helps to absorb all this bright light around us and protects us, the melanin we have in our system. And there is no reason why anyone should attempt to alter this, because God in his wisdom made us to adapt to these things. And for those with albinism, we advise they wear sunglasses, dark glasses, so that they can adapt much easier to the bright light outside. Yeah. But whatever it is, God, in fact, even the skin, yeah, people with albinism develop skin cancer at a very, very high rate because the ultraviolet rays from the sun, they don't have enough pigment to absorb them. Okay. And so, yeah, that's why almost all Africans have brown eyes. If someone has a color that is different, it means either that person may even have some, because by the way, in albinism, we have two types. We have the oculocutaneous albinism, where the skin and the eyes tell you this person has albinism, or we have the ocular albinism. Those whose skin may look normal, but the eyes have that color because they don't have enough pigment in their system. I'll
I
stop
didn't know
here.
that. I didn't know the differences. That's good information.
Yeah, yeah.
Well, so in terms of
And so,
yeah,
since you brought this up, and so you're talking about blind spots, and this is again on both sides, either the population or the healthcare givers. Most of us are ignorant. Most of us are ignorant. And so, like, we would rather, because if you see any person with albinism, the eyes are dancing back and forth if you've met any one of them. And the reason is that because of the bright light, because they may have some refractive errors, they are not seeing enough, the brain is telling them to search for the light, okay, where they can see properly. If these were seen when they were babies, most of them would be seeing better than they're doing now. And so there's a lot to do. And I happen to be involved with persons with albinism. And we are trying to come up with educational materials for both the healthcare providers. Because, you know, there are cases where the midwife starts running away when they see this white baby coming out from a black woman.
witchcraft.
You know,
I'm joking. Oh yeah, but
yeah,
I understand. Mhm.
yeah. Or you find these people with cancer, this retinoblastoma of the children, the eyes becoming big, they start giving them some creams for the eye and those things because they don't know. And so those blind spots need to be doctored somehow. so that we actually we have to look for them. We look for some of these things that are not there. And one thing I always talk to the policymakers, because if your glasses were taken away from you, how functional can you be? Okay, you are 45, you are 50 years old, they bring some check for you to sign. You cannot see clearly, you can sign anything. And so I create that awareness with them to know how important the eyes are.
Well, this is there's so many follow-up questions I would want to ask, but because we're almost getting to the top of the hour, I think I have to make room to bring you back to have some of these questions. But one of the last questions I have for you to just this session is, if we were to address what are some of the critical blind spots, very quickly, very briefly, to prioritize in the field of ophthalmologists, and
Yes.
what are some of the key stakeholders we need to not only identify but also address these blind spots? Very quick.
Okay, this is a very important question. Question, if you like, because what happens, you come, you get to a facility where everything is well equipped, but give 5 years or 7 years, you find most of the equipment are packed the corner. They are no more functioning. Um, all these equipment are not made here. They're imported from other countries. But in the West, every equipment you purchase comes with a service contract. Someone to actually how the equipment will be serviced so that you can use it for as long as possible. Fortunately, that's not the case here. And so when the machine breaks down, that's it. If there's nobody coming from outside from the company to come and fix it, even if they are coming, you have to pay for their flight, their hotel. I hope you get it. And so
I get it. Mm.
what we started doing is to train technicians, okay, on how to not to fix, because some of these equipment have their technical, so you buy something from a company, yeah, like Zeiss. They're not going to let anyone open the machine, okay? So that is one of our major things, that everything that we are using here, including the consumables, are imported. Drugs are imported. And so to make things worse, when these things are coming in, even if they are donated, you have to pay duty.
Mm-hmm.
And the cost of the duty is about the same as how much that equipment cost.
Mm.
Now, we are dealing with patients who have nothing to even contribute. And so the question is, where does that money supposed to come from? And with what is happening in the world today, I think it's high time we starting our own assembly plants or something here, so that we don't have to depend on other people. It may be a very wild dream, but we have to start thinking about them.
No, the reason I'm smiling is because I think for as long as I remember, these conversations have been the same. We need to do this. We need to improve manufacturing. We need to train out. But it's
Yes.
only stopped at conversations. And I guess my question that's running in my mind is, what really needs to happen for it to actually happen? And that is the $1 million question, because yes, everyone, I think in every presentation ends with, we need to build capacity, we need to manufacture our own thing, we need to process our products. So
Yeah.
that's the only reason I was smiling.
Well, I see it's very possible, because I'm looking at India and China. Now, India is producing they're manufacturing their stuff. China used to be the same. In fact, even if you gifted me something from China about 20 years ago, I would just refuse it politely. But now we're importing from China. Okay? We are making, again, there are vehicles manufactured in our country locally. So if we can manufacture vehicles, what stops us from manufacturing these? So it's the priorities. And I'll say this, when some of those big men need to have an eye surgery, they'll fly to London or Johannesburg or somewhere, get it done. The priorities we are talking about.
Right. Yeah.
And
yeah, go on.
I'm in a group of advocates. We are doing some advocacy, and I say it at all levels, because we have to start thinking of, if we can build vehicle assembly plants here, what stops us from building equipment manufacturing plants?
Right. I agree with you. And I know, again, we've really come up to the top of the hour, but as somebody who is really invested in communication and media and all that, what is the one suggestion you have for governments, ministries of health out there about the best way to reach out to the communities to raise awareness about the eye conditions and challenges?
Well, when COVID was here, and this is one example I can give, all the government agencies, the ministries, the military, the finance, everybody was enlisted to be part of it. And talking of communications, in fact, we have so many radio stations, we have so many TV stations. It's just a matter of giving them what to say, and they'll say it better than I would do. Again, the priorities. Because if I walk to any radio or TV station, first thing they'll ask is, they'll show you the fee structure.
The media spots.
When there are no programs, they'll be playing some of this useless music, huh? Which can be replaced by health awareness creation.
Right.
And so I would enlist everyone. I have your email address. I'll send you some articles I've contributed on who can carry out primary eye care.
Absolutely. No, this is fantastic. Thank you so much.
And you asked about other agencies. In fact, we had a project with Standard Chartered Bank dubbed Seeing is Believing. Okay? And they had about $100 million. And that effort has brought the level of eye care another step higher in Africa. Unfortunately, the project is over, and we're back to square one.
That's a point to start with next time. And how do we sustain this project?
In the eastern part of Africa, southern part of Africa, the ministries of health, finance, they take over the clearing of the equipment or the vehicle that you are bringing in to help their people. But this side, we have to actually reduce the number of consumables, number of whatever we want, so that we can pay the government for coming to help them, which is, in essence, is actually their responsibility.
Right. Well, thank you for sharing that piece of information. And I guess as we think forward to, sustainable ways, and again, I'm saying this seriously. I would like to bring you back to talk about just how to create sustainable structures to improve eye care in the region. That is a whole animal, so we can start the conversation today. So, but for now, I wanted to say thank you so much for being a guest on Healthcare Blind Spots to bring to us your experience, knowledge, and advocacy. Thank you, Dr. Wiafe.
You're welcome. Thank you,
And
Vivian.
and to our viewers, I hope you've learned a lot about eye care in at least I dare say Africa, since he's worked in different parts of Africa and comparatively with the rest of the world, the more developed worlds. And we'll continue these conversations in future episodes. But for now, thank you for watching. Till next time.